Welcome to the Jerry Pal podcast. This is Eric Guadera.
This is Alex Smith.
And Alex, there is somebody in the room with us.
We have in studio from New York City, Ben Hahn.
All the way from New York City.
We have Ben Hahn, who is a geriatrician, assistant professor of medicine and geriatrics at NYU. He works quite a bit with Allison Moore, who's at UCSD, and he studies substance abuse in older adults.
Welcome.
Hello. Glad to be here.
Before we get into the topic of substance abuse in older adults, we always start off with a song. Do you have a song for Alex?
Yes, I do. I would love to hear Bob Dylan's Mr. Tambourine Man.
Bob Dylan, frequent request for you, Alex.
Frequent request.
Right.
This is probably like, I don't know, fourth, fifth song by Bob Dylan.
Do you like Bob Dylan, Alex?
I do. Oh, he's a tremendous lyricist. He doesn't sing, but he's a tremendous lyricist. This song in particular is just a wonderful, vision, fantastic song. We'll do a little bit of it, and then we can talk more about it. Hey, Mr. Tambourine Man, play a song for me. I'm not sleepy and there is no place I'm going to. And hey, Mr. Tambourine Man, play a song for me. In the jingle jangle morning, I'll come following you. Mr. Tambourine Man.
What does that mean?
Right, I'm not sleepy. Mm-hmm. What do you think, Ben?
Is it about substance abuse?
So it could be. There's a lot of different interpretations, like all Bob Dylan songs. So maybe he was high or under the influence and he saw someone like Mr. Tambourine Man, or maybe Mr. Tambourine Man is a drug dealer.
I mean, it has such great sort of, visions and dreamy lyrics. Though I know that evening's empire has returned into sand, vanished from my hand, left me blindly here to stand, but still not sleeping. This is poetry, and it's psychedelic sort of poetry, right?
Right.
I've heard that he was also a member of a person who played guitar on this track who used to wander around with a giant tambourine at night. Mm-hmm. And Bob Dylan claims that's who the song's about. But it's up to our own interpretation.
Mm-hmm.
Huh. Well, it is a good segue to the topic at hand, substance abuse in older adults. Is this an issue? Is this an issue that we have to worry about when we care for older adults?
Yeah, just to be clear, when you age, you stop using all drugs and drinking because older adults are pure.
You turn 75,
and
you no longer...
Never. Right?
Yes, it is. So traditionally, older adults have not had very high rates of substance use, aside for alcohol and tobacco. But this is changing dramatically. A lot of it's the baby boomer generation, which has higher rates of substance use compared to any generation preceding them. And as we know, they're getting older and they've a big population size. We're definitely going to see a lot more older adults with substance use issues than we've ever seen before.
Can we just clarify what substance abuse means? Now, when I hear that term, I generally think of non-alcoholic substances, but in our sort of conversation before this, you were intimating that it does include... so what falls under that umbrella of the term substance?
So substance, includes alcohol, tobacco, drug use. We're trying not to use the term abuse anymore, substance abuse, and more medical terms like substance use disorder, like DSM-5 criteria. So you can say alcohol use disorder, which...
So why are we moving away from abuse and going to use?
So language matters, and so especially around drug use, it's been highly stigmatized. So we try to avoid, we're really focused on trying to avoid terms like abuse, clean, dirty, addict, junkie. Like these terms are very stigmatizing, and they prevent people from getting care. And I've seen that before. I've seen people who are in treatment programs who refuse to go to primary care because they feel like they're going to be judged.
Right.
And so a lot of that is surrounding the stigma of drug use.
Right.
But if we put it in the context of this is a chronic disease, it's lifelong. Many times it's relapsing. Just like I have a lot of patients who have diabetes who's all over the place, and We don't punish them. We don't, use negative terms.
It also sounds like just because they've turned 65 or 75, this is still an issue.
Right. Correct.
How big of an issue? Like, do you have data on like whether it be alcohol, marijuana? Is marijuana considered a substance?
Yes, it is.
Yes.
So our
Hard to tell sometimes.
So a recent paper we did looked at. So I've been using a lot of I've been using data from a national survey. It's called the National Survey of Drug Use and Health, and it's really that's how we get prevalence estimates for drug use for the United States. Mm-hmm. And so I've been really focused on those 50 and over, and looking at kind of the patterns that have changed in this population.
Yeah. So how well does this survey capture older adults?
So it's supposed to be nationally representative. So the weight percentage is supposed to be representative of the entire country, but it doesn't include people who are institutionalized. So, they don't do this in nursing homes, people who are incarcerated. They try to pick up people who are homeless, but, that's obviously, there's a lot of barriers to doing that. So it's supposed to be nationally representative to a certain degree.
Mm-hmm. And maybe we'll take one substance to start with. So what does it say about marijuana use among older adults?
Right. So marijuana use is unique because, as laws are changing throughout the country, and views on it are changing quite a bit. So we did a study using the National Survey of Drug Use and Health in 2005 for people over 65, people who are 65 and over. The prevalence of past year use of marijuana was 0.4%. And
0.4. Wow,
right.
that's
so not
super
that many,
low.
right?
0.4% of
people over 65
had used marijuana in the past year.
Right.
Year.
Right. And so the most recent data from that paper, we combined 2015, 2016 data. It was, I believe, 2.9%. Yeah.
So marijuana use still pretty low. I was expecting a higher number than that.
Right.
Maybe because I live in San Francisco.
Right.
Maybe the Bay Area.
But we also saw huge jumps in people aged 50 to 60 to 64. So that prevalence for them is about 9%, when before previously it was like 2%.
Oh, so it is a younger, older age.
Right.
Probably, like you said, will continue to increase.
Right.
Yeah, and the question is, how many people over their life course who have used marijuana at younger ages stop using it as they get to middle age, or these people who are the young old, how many of them will continue to use as they get into the old categories?
Right.
And do you have any information about that sort of thing, or how many people start using it in old age?
Right. So it seemed the data we looked at, it seemed like the people over 65 and over, they had first started using after, I think we looked at it. They started using later in life, while as the people who are age 50 to 64, almost the overwhelming majority of them used when they were teenagers. We don't have data because this is cross-sectional, so we don't know exactly did they use as a teenager, stop and restart. But I suspect a lot of just clinically, I have a lot of older patients ask me about marijuana, and they said they grew up in the time where attitudes were changing about marijuana. So they in the 60s. They tried it then, and then haven't used it since. But now, because it's getting all this press about, laws are changing, maybe it could be helpful for different symptoms. They're wondering about it now.
Right. Medical marijuana.
Medical, right.
So what do you tell them when they're in your office? They're I was thinking about,
Right. There was a New England Journal article about this just last couple weeks ago, right? Medical marijuana for pain, and one person argued for and one person argued against.
And Journal American Geriatrics Society just had an article on marijuana in older adults.
Jags.
We'll have
heard of that journal.
Right.
That's a good journal.
I cited that paper in my article. So
what do you tell the older adult who is thinking about using marijuana again? Right.
So where I live is the laws are different than here. Right, so in New York State, there's medical marijuana, but you have to meet qualifying conditions. So recreational marijuana is not legal like it is here, right?
We've had medical marijuana legal for 5 years, maybe longer, and recreational marijuana as of last year.
Yeah,
right. That was the ballot last year, 1 year ago.
But just because it was illegal before.
It doesn't mean it wasn't happening.
I'm not sure it changed
Right.
that much.
Right. So it's a little bit different because if someone meets the criteria, then I can refer them to someone who can prescribe the medical marijuana and they can go to dispensary. Whereas someone who, in most cases, the patients I see don't meet criteria for it. So that's kind of a different story because one thing I warn patients is that the THC concentration in marijuana today is studies have shown it to be a lot stronger than what it used to be, 30 years ago. So if they're used to a certain type of strength of marijuana, it's probably very different now than it was before.
Yeah, I just went to a really great talk on use of marijuana, both medically and not. And it is so complicated now because it's not just kind of what you're getting, it's how are you going to inhale it? Are you going to use it as a brownie? Thinking about time to onset, thinking about like if you have an edible or you use it like an oil, knowing that maybe in half an hour you won't feel anything, but that doesn't mean you just keep on eating it because in 4 hours you'll be knocked out.
Right.
And then also thinking about like testing the marijuana that you're getting to see like the THC content, like the all the other components of marijuana, and actually tailoring the type of marijuana to the symptom and potentially the disease that you're trying to treat. It sounded like you needed a whole nother marijuana fellowship to figure this out.
Right. So I think a lot of this we don't know because there are federal restrictions to really studying it, and so a lot of studies come from other countries. But you're right. There's a thing a lot of dispensaries have to tinker with is the THC, which is a psychoactive component, to like CBD. And really what ratio works well for what symptoms and what ratio minimizes side effects. And so, as we know, older adults are more susceptible to side effects. And so these are questions that we really don't know the answers to.
Do you tell them to watch out for any particulars? Like what side effects are you worried about in the older adult with marijuana?
So I worry about dizziness, somnolence. I worry about falls. That's something I'd love to study and see, because we know for alcohol, we've studied a lot about alcohol. Alcohol increases your risk for falls. We see, there's data on that. But for other psychoactive drugs, such as marijuana, there's a lot we don't know. And so
does it increase risk of falls? There was a recent study about cognitive impairment in people who are using marijuana. I think they took people who used marijuana heavily. And I believe they had one group abstain and the other group continue using. And the memory scores improved among the abstainers.
Yeah, I saw that too.
Yeah, and you worry about cognitive decline in the elderly. Is this enough? Is it going to tip you over into dementia? Is it going to make you have difficulty tracking your medications, taking them correctly? Adherence rates, etc. Yeah, you're going to get a financial incapacity as a result. Yeah, for many frail older adults who systems vulnerable to stressors, and this may be a stressor. On the other hand, maybe it's better than the opioids for pain. So there are these trade-offs here of, there's no best answer. So what has the least harms and the most benefits for the individual patient in front of you? And marijuana potentially should be in that conversation.
The problem is we just don't know yet, really.
We don't know.
What the benefits? Do the benefits outweigh the potential harms? And for what patients does it? Is it most appropriate for?
So will NIH fund studies in this area?
I think it's complicated.
It's complicated.
I think there's some. If you want to do an NIH study with marijuana, I think you have to get the marijuana from certain sites that are federally approved. It's okay. I think I don't know that much about it.
Yeah.
Any other advice for clinicians for thinking about marijuana, older adults, things that we should be talking to our older adults about?
I always start off by telling patients, I say I don't know, right? And they think that's funny because they don't like to hear that from their doctor. That I have no idea. I don't know what the potential benefits. Usually, people come to me is they want to try it for pain or for sleep. Something that as geriatricians we see all the time, and it's very difficult, right? Because we try not to use benzos and we try not to use opiates. So I start off by saying I don't know. It potentially could be beneficial, but I worry about the harms, which are not we don't know about the harms really at this point, and so I can't really give a straight answer. I think it's probably safer than opiates for certain patients, but there's no way I can really say that that strong of a statement confidently.
Okay, related question here.
Uh-huh.
Let's say you have an older adult who's in there for a standard office visit. This is not about asking about medical marijuana for pain.
Right.
Should you screen them for marijuana use? Should you ask about it?
Right. Absolutely.
Absolutely.
I ask all my patients about everything.
Once a year or every visit, and how do you do it and why?
It depends on the patient. The patients I know very well. And I kind of have a sense of what their home situation's like and what they're like. I might not screen them that often, but every new patient, I ask about alcohol, tobacco, the variety, drug use, including marijuana. I ask about cocaine, because at least in New York City, some older people still use cocaine, and potentially dangerous, especially if you have underlying cardiovascular disease.
Mm-hmm.
So I think it's important.
So let's talk about that. Let's move up this food chain. What about alcohol use? I think that one probably more people think about when they think about like substance use. Well, they probably don't think alcohol often as a substance, but it sounds like we should be thinking about that.
Definitely. And the thing that what we've been seeing from using the national data is that for older adults, it's really a large percentage have problems with binge drinking. And I think a lot of older adults don't realize that the guidelines recommend lower drinking limits as you age, because there are physiological changes of aging that can make you more susceptible to problems with alcohol.
Did you say binge drinking?
I work so
like the stuff that we hear about, like college party. Like
right.
Usually when we hear binge drinking, I think the usual thought is, like that's something that people do in college.
Right. So the recommendation for older adults from the NIAAA is men and women over the age of 65 shouldn't drink more than 3 drinks in one day. And if you have certain comorbidities, it should probably be less. And so a lot of people, they don't think drinking 3 drinks is binge drinking, especially when they were younger.
Yeah.
And so I have a lot of patients when they get old, they're like, I've been drinking a 6-pack when I see my friends, occasionally. I've been doing that forever. They don't consider that really binge drinking. But because the definition changes as you get older, you are now binge drinking.
What is? Do you know what the definition is for younger folks?
So it is, I believe for men it's 5 or more, and women it's 4 more.
Mm-hmm. So it's a pretty big change to go from that to 3.
Right.
Yeah.
2 beers knocked me out.
1 for me. What comorbidities in particular are you worried about with alcohol use?
So obviously liver disease we worry about, but also hypertension, cardiovascular disease, people with heart failure. Yeah, and I also worry. So I got really interested in this topic of like the intersection of chronic disease and substance use, really from my home care panel when I was in fellowship. And I remember Cynthia Boyd, does multimorbidity, and she had that paper on like a schedule for someone with several chronic conditions and what their daily life is like, all the things they need to do per their guidelines. So it's difficult to do that in general, but then I was seeing patients who were drunk all the time at home. And so imagine doing that if you have multiple chronic conditions and then binge drinking. How are you going to do all the things you're supposed to do for your different diseases?
So how common is binge drinking in older adults?
The last data we looked at 2013, 2014. So among people 65 and older, the prevalence estimate of people reporting past month binge drinking was 9%. And those between age 50 to 64 was 19%.
19%.
And that's actually using not the lower cutoffs for binge drinking for older adults.
Wait, what cutoff are we talking about
We
here?
use the standard one, just
which
You
which
mean
is
like
how much
5
again?
and
5
4.
and 4, right?
Yeah.
So that's
5
it's
for
actually
men,
going to
4
be
for women.
higher if we. The problem with the survey, they don't use the lower cutoff for older adults.
And it was 19% had 5 drinks or more over or
The last
In
at
a
one
day.
point in the one day in the last month, if they were a man, or
Wow.
4 or more in one day if they were a woman.
1 out of 5.
Yeah.
Wow.
So that's. Yeah, so we're actually gonna the new survey for 2017 is gonna come up soon, and so we're gonna take a look and see if that's changed at all since 2014.
Right, and you expect it may be going up.
Right,
Looking
and
at
so-
time trends.
Right. So we're gonna try to use the lower cutoff because I think now they have that available. So
Yeah, this is common enough that I agree with you. We should be asking about it
Right.
with our patients.
Is cage questions still a thing, or should I what?
So the
What's
problem
new?
With, the problem with cage is that it won't pick up binge drinking, which
Oh, right.
so that's the problem. So because I have a lot of
Learning.
patients who will
This is great.
they won't drink. They'll drink maybe once a month, like socially, and so that they only drink one time a month. But that one time they'll drink like 6 or 7 drinks, and so they don't think that's a problem. Like I'm thinking I have a patient who has heart failure. He's like, that's not a big deal, just once a month, just with my friends. But the fact that he's drinking so much in one day, that's potentially problematic.
Can you say more about why binge drinking is potentially problematic? Because I think we've all heard about people who have chronically used
Right.
alcohol and drink and have cirrhosis, etc.
Right.
What are the issues with binge drinking? Are they the same or are they different?
So, I don't think that's, as bad as someone who has like alcohol use disorder, who has liver cirrhosis, but, that episodic binge drinking, can suddenly increase your blood pressure. If you have chronic diseases, you might not take your medications. And yeah, it can exacerbate heart failures, something I worry about.
Falls and all the other consequences
exactly.
of intoxication.
Right.
Right.
Okay, how about should we move on to
Sure.
what are other substances of use or unhealthy substance? What word should I be calling this?
So I use unhealthy substance use.
What other unhealthy substance use is common in older adults?
So tobacco is also one, but I that's not really my.
That's not your
research.
area.
How about other things? How about like cocaine, heroin, LSD, I don't know, all of those.
Right. So the prevalence rate.
Methamphetamines.
Well, so that's actually interesting. So the prevalence rates for those are still pretty low for older adults. Like I'm talking like less than 1%.
Less than 1%.
But we're likely going to see a change in this as the baby boomer generation gets older. So I work in New York City. And I specifically work in. My research is focused on older adults who are in opiate treatment programs for heroin and prescription opiate misuse. But that's a very different population than the general population. So I don't know if that's.
Yeah, prescription opioid misuse is another.
Right. So that's what I'm in town to present. So using that same data, so I looked at prescription opiate misuse among older adults. So it looked like the prevalence for people 65 and over was, I think, 1.2%, which is much lower than other age groups. But older adults are prescribed opiates at much higher rates than any other age group.
Yes.
So what do we mean when we say prescription opioid misuse? Are you saying misusing opioids that somebody prescribed you, or misusing pills that you can also get on the street or elsewhere?
So it includes both.
Any type of like misusing OxyContin, no matter where you get it, or other opioids.
Right.
What was the prevalence again?
I have it in my bag, the exact one.
But it's about 1%.
Well, about 1.2%.
1.2%.
Yeah.
When previously it looked, the problem with the survey, it always includes, it lumps people 50 and over together.
Yeah.
And so as a geriatrician, I find that problematic. So that's why these papers that I'm trying to, break it down 50 to 64 and then 65 and over. So in 2005, the prevalence of opiate misuse among those 65 and over was like 0.5. So now it's
so it may have doubled
Right.
in that period of time,
Right.
and we may expect it to continue to rise given the opioid epidemic
Right.
and the aging demographic, the baby boomers aging, higher rates among baby boomers.
right.
Yeah.
Well, it's interesting. So, I remember going in med school way back when we were taught things like cage questions and also ask about substance use and illicit drug use, like non-specific questions. How should we ask questions that can bring up issues like unhealthy or prescription opioid use? Wait, what's the term again?
Misuse?
Misuse.
Right. Well, so when you're talking about, so the stigmatization of, drug use is still a big problem.
Yeah.
And so, especially for older adults who really live through, the negative language, punitive language, or the war on drugs, right? We, hopefully as a society, we're thinking of more of as a chronic disease. But previously, the language wasn't about that, right? And so for older adults, they live through, this punitive language. And so that's why when I screen patients, like to make sure not to use language that, not to use those kind of language. So I ask, I start with alcohol, and I usually use one question.
Okay, we're gonna role play.
All
Ready
right,
for a role play?
play.
I
First
am your
time, Jerry
patient.
Powell.
Okay. All right.
Ask me the question. Ask me the questions that you would ask.
So-
Because
okay.
I want to do this now.
Okay.
Like,
So in the past year, how many times have you drank 3 or more alcoholic beverages, which I count as one drink is 12 ounces of beer or 1.5 ounces of shot or 6 ounces of wine? How many times have you drank 3 or more and on one occasion, one day in the past year?
I never drink.
Okay, so you would likely have screen negative for...
Alcohol out.
All right.
Right.
And next?
Next.
So I asked about smoking. I say, do you smoke currently or use any tobacco products?
I do not use any tobacco products.
Have you ever used in the past?
No.
Okay, good. So then I move on and say, so I'm going to ask you about, other drugs that some people, continue to use when they're older.
Yes.
So have you used cocaine at all in the past year?
No.
Okay. How about have you used any injection drug use in the past year?
No.
Have you used any prescription drugs that were not prescribed to you? Oh, yeah, I would know if you're on. Oh.
Yeah.
Have you used any prescription drugs that were not prescribed to you, like pain medicine or medicines for anxiety?
No.
Okay, good. I talk about injection drug. Have you ever used any drug by injection?
Yeah, lots of heroin.
Okay. When was the last?
I knew there was going to be a positive in here. It's just
Okay, that's okay. So so when's the last time you used?
Great. I mean, that very non-judgmental. Didn't even faze him.
Right,
Yeah.
right,
So
right.
then you're trying to get more of a history, kind of how often I'm using it,
Right.
my safety around using it, like
Right.
where am I getting needles, things like that.
Right.
Mhm.
Right. And so I mean, I work with trainees, with fellows, and they
Yeah.
always, why am I asking the 95-year-old grandmother, if she uses drugs and uses drugs or alcohol, and they find it uncomfortable? But you pick up things, right? Like I pick up things all the time. Like
Yeah, who knew that the Jerry Pell podcast co-host was using
Right,
heroin
right,
regularly? Lots of heroin.
Don't
Right.
judge me.
Right, we can't judge him
He
based
didn't
on
judge
his
me.
radio
Why-
personality.
Why are you judging me?
Clearly.
You didn't judge me.
Right.
we have to put in the context of your overall health, right? So
That's right.
yeah.
That's great.
By
So,
the way, I do not use heroin every day.
just for the record,
Every other day.
in case anybody at the VA is listening. Interesting. So here's a question. What's the most surprising? So you talk about like the 95-year-old grandmother.
Right.
Have you had clinical scenarios that are somewhat surprising? Well, I asked, and wow,
Right.
who would have thought?
Right. So I definitely do. Like I there's a patient I saw. I thought I knew really well. She's 95, but fully functional. Still working. She works at the
Still working at 95.
right. She works at a restaurant. She also works at polling places. But I asked her. I didn't. I admit I didn't really ask her about alcohol because I just assumed she didn't. But then one day I was like, I had this student with me. I was like, oh, I should really be a good example.
Model what
right?
I teach.
So when is the last time you drank alcohol? And she said, oh, this morning. Since I was little, I always drank. I took my medicine with alcohol, just a shot of brandy. And she said, 30, 40 years ago, it used to be just once or twice a day. But as she's taking more medicines, like she's
That's a lot of brandy now.
right, exactly.
One for each
and
pill.
then she's wondering, sometimes I feel dizzy. Like, 'cause she'll take her morning medicines with a shot of brandy and then go to work or, go out because she's still fully functional.
Right.
She's like, I started to feel dizzy and not so good, and and there was one I had to put her on a TID medicine, and she was like, I just
that's 3 drinks of brandy
right,
a day.
exactly,
right.
And so I was kind of taken aback, and I was like, oh,
that really brings it home, right?
Right.
We need to ask about this because it's increasingly common. It's more common than we think,
right?
And it may surprise you who's actually using.
Right.
Using is okay.
Right. Yeah.
Is using?
I was trained in an era where we said abusing, so that
Right.
language slips in every once in a while.
Right.
But
that's okay.
drinking.
Drinking.
Yeah.
Mm-hmm.
That is fascinating.
Anything else that you teach trainees that you think me and Alex should know?
So my career focus is really trying to bridge geriatric medicine with addiction medicine. That's kind of what my career path is. And as I was entering more into the substance use world and looking at like principles of treating substance use disorders, harm reduction, I realized a lot of those principles are very similar to geriatric medicine principles. Patient-centered, non-judgmental, not so much a focus on, I'm just going to cure you, fix you. It's working with patients, what their preferences are. And so, I found that really fascinating. And so that's what I hope to bring into both fields.
Well, that was absolutely fabulous. I learned a ton.
Me too.
Including, like, I don't usually think about asking about binge drinking. I think about asking about alcohol use, and I think for a lot of geriatricians, they think about alcohol use, but the idea of like the binge drinking or just the idea of like the pills, because I think that brandy with pills is
Yeah,
probably a lot more common than we think. But I just want to thank you a lot for joining us
Thank
today.
you much for coming out
Maybe,
to our studio.
Maybe, to our lovely studio. Maybe we can end with a little bit more Mr. Tambourine Man. Maybe we can get some more of those lyrics to
Thank
figure
you,
out
Ben.
what's going on here.
Though I know that evening's empire has returned into sand, vanished from my hand, left me blindly here to stand, but still not sleeping. My weariness amazes me, I'm branded on my feet. I have no one to meet, that ancient empty street's too dead for dreaming. And hey, Mr. Tambourine Man, play a song for me. I'm not sleepy and there is no place I'm going to. And hey, Mr. Tambourine Man, play a song for me. In a jingle jangle morning I'll come following you.
And with that, I'd like to thank all of our listeners for joining us this week. If you have a second, please rate us on your favorite podcasting software or iTunes. And we look forward to you joining us next week. Goodbye.
Thanks, bye.